I'll be sharing this presentation, as mentioned, with my colleague Shuchita. And Annie Portela is also connected and will be supporting the questions and answer session. So today we will be sharing with you the WHO recommendations on maternal and newborn care for a positive postnatal experience. But before we do, we enter into the topic, I wanted us to do a short exercise. And I wanted to ask you to think about your own postnatal experience. This could be with your own child or children. It could also be someone from the family, a niece or a nephew, even a neighbor or someone you know. And just try to remember how were these first moments after giving birth or after the baby was born, all this feeling when you got back home, if you went to a hospital to have your baby, or the first hours, the first days at home when you deliver at home. And let us just pause here and try to get all these things back to us. I think that as from the different reviews we did to develop this guideline, looking at what women and families say they went through this postnatal period or the things they need, you probably have a bit of shared feelings, a lot of joy and happiness because mom and baby were healthy, they were thriving, baby was breastfeeding, that smell, they are so little, right? Everybody wants to have them on their arms. But at the same time, sometimes mom can be a bit tired or, baby's crying all night. Sometimes it's not that easy, right? And that's in general what women and families say across the world. So if you attended the last webinar early March, so you heard about recommendations on intrapartum care for a positive child experience. And today, then we will be covering the follow-up. So what happens after childbirth, give you a background, explain to you the scope of the guideline and highlight some of the key recommendations, as well as show you some of the resources we have already available to help you implement these recommendations. So for the background, what we know is that the burden of maternal mortality and morbidity remains very high during the postnatal period or after childbirth. And we know that there's plenty of opportunities for us to increase maternal well-being and also support nurturing newborn care. And these are not fully utilized. We know that a third, so 30%, or that about of maternal deaths will occur postpartum. There's also high mortality among newborn babies. So 17 in every 1,000 live-born babies will die during the first month after birth. And deaths are more common in the first days right after birth. And then we also know, for example, that in low middle income countries, around 1 in 5 women will experience perinatal depression or other type of mental health issues that will, of course, interfere not only with her own health, but also in how she can take care of the baby. And we have other issues also related to coverage and quality. And what we see is that postnatal care coverage and quality lags behind when we compare it to other maternal health, newborn health indicators. The first figure you can see here shows for how long women stay with their babies in health facilities after birth, and this is for vaginal birth. And what you can see is that in some countries, they will stay only a few hours, not even a day, and this is the yellow or the light green. But then in other countries, for example, then women will stay for much longer, even probably too long, over 5 days in some places. The figure at the bottom shows some indicators of coverage across the continuum of pre-pregnancy, pregnancy, postnatal period up to childhood. And what we highlighted here is that you can see that coverage of postnatal care, and this is within the first 2 days after birth, so very, very early after childbirth, is low. And it's low when you compare it to coverage for other interventions across that continuum. So a lot to do to have better coverage and also better quality of postnatal care. Let me spend some time explaining what is the postnatal period, how we define it, and because these are the definitions that we use in the WHO recommendations. So we define it as the period beginning immediately after birth of the baby and lasting up to 6 weeks, so 42 days after childbirth. And there are 3 main subperiods in postnatal care period. So that immediate postnatal care, that is the first 24 hours. And I just take the opportunity just to highlight that in this guideline, what we cover is the care that women and babies should receive after the first 1 of 2 hours, because the intrapartum care guideline is covering that immediate care that women and babies receive, often in labor ward or at home, but in the very first minutes and the first hour after birth. So we won't be referring to third stage of labor or the first hours after birth today. Then the early postnatal period is basically the first week after birth, so from day 2 to day 7, and we have the late postnatal period that goes from the 2nd to the 6th week after birth. What is in postnatal care? So the objectives are to maintain and promote health and well-being, both of the woman and the baby, to identify any risks they may have to develop complications, for example. So, and that it's done by different assessments or screening for certain conditions, and we will be talking about some of them later in the presentation. Another objective is to prevent any of these complications. So once risks are identified, or if there's any preventive measure that apply to all women or all babies, these have to be provided during the postnatal period. But then it has also big component on fostering support from health services, but also from families and communities, and how the communities and the health workers can support women and babies to go through this period as well as addressing any other health-related or social needs that may also have an impact in their health or their capacity to either care for themselves, for the woman, or for the woman or the parents, the family, to care for the baby. We published these recommendations. It was exactly a year ago, end of March 2022. So it's really nice to have this webinar today and celebrate that 1 year after the publication of the guideline. The guideline looks at improving quality of essential postnatal care with the goal of improving maternal, fetal, and newborn outcomes. It has in total 63 recommendations, but half of them are existing recommendations from other WHO guidelines that are relevant to postnatal care, and therefore we integrated them in this document so you can find all the recommendations in one place. But then we have another half, 31 recommendations that are new or have been updated from previous documents. And we will mainly spend time today around these new or updated recommendations, but we'll refer to some of the existing ones that we thought were important to highlight. The guideline has 3 sections, or we divided the recommendations in 3 sections: those related to maternal care, those related to newborn care, and those related to health systems and health promotion. And this is the way we will present them now. Regarding the guideline scope, is a guideline that is relevant to all women and adolescent girls in the postpartum period, so these first 6 weeks after birth, and their babies. And this is for any healthcare facility or any community-based setting, unless it is indicated in the recommendations. And we have some that are, for example, context-specific or specific to certain settings. The guideline highlights a postnatal care model where we place the woman and the newborn at the center of that care, with that continuous support throughout the first 24 hours, and then across those 6 weeks, that is provided by the families and the health services. And it covers assessments and preventive measures, interventions to prevent some common maternal issues, prevention and early identification of mental health conditions. It touches on maternal and newborn nutrition and breastfeeding, infant growth and development, postpartum contraception, discharge processes and preparedness when birth are in health facilities, as well as interventions to support self-care, care-seeking practices, and family support in the home. And this, of course, has to be supported by functioning health systems with supplies, medicines, and equipment, competent, motivated health providers, effective referral systems if any complications are identified that need additional care, and all provided in a respectful, individualized person care center approach. So let's start maybe going through some of these recommendations, and the first set of recommendations I will present before asking my colleague Shuchita to join me is around maternal health. So as you can see on the slide, we have a renewed focus on maternal well-being, and there's a whole set of recommendations that are not only looking at kind of more clinical interventions, but recommendations to ensure that women feel well throughout that postnatal period. So recommendations on providing or offering to women pain relief for uterine cramping after childbirth, or for any breast or perineal pain they may have. To counsel and support breastfeeding, not only as a way to promote breastfeeding, right, that it's very good, but also to prevent breast complications, engorgement, for example, or mastitis, and advice on diet, including iron supplementation and physical activity as early as possible in the postnatal period. However, this one intervention we look at that is not recommended in routine, and this is on pelvic floor muscle training that is started after childbirth, looking at preventing postpartum incontinence. This could be urinary or fecal incontinence. And this is because we found that this intervention was at least not effective as desired for preventing. We didn't look at this intervention for treatment. If the woman has incontinence, for example, this is only looking at prevention and is not recommended routinely. Moving to maternal assessments, there's integrated recommendations on doing HIV catch-up testing for women known as HIV negative or unknown status because they miss, for example, early antenatal or late pregnancy HIV testing. And this is mainly looking at prevention of mother-to-child transmission of HIV. And another integrated recommendation is on a screening for tuberculosis disease in postpartum women, as well as any household contacts for that woman or the baby. These two recommendations are context-specific, so they are recommended in settings with high burden of HIV or TB. So it will, of course, depend on the epidemiology of the disease in your settings. There's another recommendation around assessments that is important to highlight. This is a new recommendation for a screening for common maternal mental health conditions. And this is referring to depression or postpartum anxiety. This is an intervention that will need effective systems to refer women if they are screened positive as or identified as kind of risk of having postpartum depression or postpartum anxiety. It will need confirming diagnosis, for example, and being able to offer management and follow-up as needed. It's important to ensure that these services are integrated into routine postnatal care, and of course that health workers are trained and supervised to carry out this screening in a culturally sensitive manner, and of course that they know where to refer women, or even they are trained to provide some of the management that and support that might be needed. You will see here at the bottom of the slides that different additional WHO documents that have been published and are available to support implementation of this recommendation, including how to train community health workers to do this screening and management of any mental health conditions in the community, and a guide for integration of perinatal mental health in maternal and child health services that was published just a few months ago. And that's why I wanted to highlight it. The last recommendation I will highlight is on postpartum contraception. And again, this is an integrated recommendation that supports provision of contraceptive information and services in the postnatal period. It's something that should be offered to all women and couples. And this is regardless the mode of birth, either vaginal or cesarean section, or whether she is breastfeeding or not. Again, important to ensure that health workers have all the competencies and skills to provide these services, provide contraceptive education, information, and ultimately the chosen contraceptive method. And again, I put here at the bottom of the slide, there has been an update published end of last year, the Family Planning Handbook, where you can find more information on the different methods that can be offered during the postpartum period, but also to help implementation. So I will pass over now to my colleague Shuchita, who will cover the newborn recommendations. Over to you.
Yeah, thank you, Mercedes. So good day, everyone. In these guidelines, we are talking about term, normal birth weight, healthy newborns. And I know that there are some recommendations on the newborn which have been covered in the intrapartum care discussions, but I will touch upon all the key recommendations regarding newborn that will help you understand the continuum of care that a newborn should receive starting right after birth. So all these newborns who are born at term, normal birth weight, and otherwise healthy, they do not have any risk factors or any illness, all such newborns should be kept in skin-to-skin contact with their mothers in the first hour after birth. This helps in preventing hypothermia and also in promoting breastfeeding. They should be put to the breast as soon as possible thereafter, and the mother and the baby should be kept together on a 24/7 basis in a warm room, and the newborn should be adequately clothed to prevent hypothermia. And that would mean at least 2 layers of clothing, mittens, socks, and at least a head cover. Now, most of these newborns who do not require admission to the newborn unit, they are usually transferred with their mothers to the postnatal care wards, and from there they are discharged. Such babies, at every postnatal contact, whosoever is looking at these babies in the postnatal ward, it could be a nurse, it could be a midwife, it could be an obstetric or a gynec care provider, whosoever, or even someone from the newborn side who does the round in these postnatal wards, this person should assess the newborn at each postnatal contact. And one of the key assessments as recommended by the guidelines is the assessment for the danger signs. So the guideline says that at least they have listed a couple of signs that the newborn should definitely be assessed for, because these are very common danger signs in an infant, and they would help us identify an infant who might be at risk of becoming seriously ill. Some of these signs are that the infant is not feeding well, has a history of convulsions, fast breathing with the breathing rate of more than 60 per minute, severe chest indrawing, not moving spontaneously, fever or low body temperature, and any kind of yellowish discoloration of the skin in the first 24 hours after birth, or if the palms or soles are yellow at any age. And if there are any such danger signs, the newborn should be referred to a person who can take appropriate care of these babies. And the parents and families should also be apprised of these danger signs, that in case they identify any of these signs, they should be able to seek care from an appropriate provider. Then these facilities where there are mothers and newborns, all these facilities should provide maternity and newborn services. Facilities that are providing maternal and newborn services, they should have a clearly written breastfeeding policy, and it should be routinely communicated to the staff and the parents. And the staff who's supporting the mothers and the families or other providers with feeding services, they should have sufficient knowledge, competence, and skills to support the women to breastfeed. All the babies should be exclusively breastfed from birth until 6 months of age, and mothers should be counseled and provided with the support for exclusive breastfeeding at each contact. The routine newborn immunization, as recommended by WHO or the national guidelines, should be followed, which includes a birth dose of OPV, BCG, and hepatitis B. Next, please, Shri. The other aspects of routine newborn care, and these are all new recommendations, are that gentle whole body massage of the newborn may be considered. It helps to promote growth and development of the baby. And all the babies should be put to sleep in a supine position. So on their backs, they should be made to sleep on their backs in a supine position during the first year of life, which decreases the risk of sudden infant death syndrome. The first bath in the newborn should be delayed for at least 24 hours after birth. So it could be any kind of bath. It could either be a dip bath or, any other kind of bath, like wiping the entire baby, any kind of bath. It should be delayed for at least 24 hours after birth. There is a common practice, and I'm not sure how it is in the Myanmar setting, but there is a common practice of routinely applying some emollients on the baby's skin. Like it could be an oil, it could be a cream, it could be some kind of an ointment, but routine application of topical emollients. Topical means over the skin. The topical emollients in these term healthy newborns for the prevention of any kind of atopic dermatitis or other skin conditions, it is not recommended. Next, please. In terms of cord care, now this is an updated recommendation. Earlier, the WHO guidelines said that the clean dry cord care is recommended, but allowed the use of chlorhexidine in certain conditions. But now, WHO recommends only clean dry cord care. That means nothing to be applied to the cord after birth. So once you clamp the cord, hand over the baby to the mother, nothing needs to be applied either by the health providers or the parents or the family. The guidelines do mention that if in certain settings, there is a practice that, some harmful traditional substances are applied on the cord, for example, animal dung, then specifically in those settings, then instead of those harmful substances, daily chlorhexidine can be applied, but only in the first week of life. But this applies only to those settings where there is a common practice to apply these harmful substances on the cord. Otherwise, the cord should be kept clean and dry, and nothing should be applied on it. Next, please. Now, there are some key new recommendations on universal screening of the newborns. Now, most of the newborns, it is recommended that before you discharge the mother baby from the hospital, they should receive a comprehensive physical assessment. So they should be examined from head to toe. All the newborns should be examined from head to toe for any danger signs. That is one. But then there are other issues that the newborns need to be examined for. And those are like if the baby has any kind of visible birth defect, any kind of problem with the illness, any other sign of illness besides the danger signs that might require intervention. But along with that, there are some types of screening or tests that can be done to detect conditions that are not directly visible to the eye. And these conditions are hyperbilirubinemia, that is, it is the increased level of serum bilirubin in the blood. While the increased serum bilirubin levels would manifest as jaundice, sometimes what happens is that when the health provider is examining the newborn, they examine the newborn clinically, okay? So they look for the yellowish discoloration of skin, but they sometimes might pass it off as, oh, it's not significant, you know? So they might just think that it's not severe enough and it's normal for the newborn. And because this assessment, this visual assessment is so subjective, you know, it could vary from one health provider to the other. One person might think, oh, this jaundice is up to chest. The other provider might think, oh no, it is up to the abdomen and we should get a serum bilirubin done. So this visual assessment has been shown to be not very specific, and it could vary from one health provider to others. So therefore we say that besides the clinical examination, all the newborns should have a transcutaneous bilirubinometry done. And what is it? It is a simple bedside test. So it's just like a small instrument like your mobile, and even smaller than a mobile. It's like a very small instrument which you can put over the chest or the sternum of the baby, and it would give you a reading of how much serum bilirubin is there. And based on that, you can decide whether the newborn requires a serum bilirubin or not. Okay, and based on that, the decision for phototherapy or any other treatment might be taken. And it has been shown that if you do this, it is better than simply a visual examination, and it decreases the risk of readmissions. So if you just look at the newborn, send them off, then it is likely that they develop higher levels of jaundice and they are brought back for readmission. But if you do this TCB, it is likely that you are able to identify more babies who require any kind of intervention, and then you provide that intervention before you discharge the baby. So WHO recommends now that you do a TCB, a transcutaneous bilirubinometry, for all the healthy newborns at the time of discharge to decide whether they need any TSB and subsequent management or not. The second thing we are recommending is that you should look for eye abnormalities. So again, normally clinically, we just look at the eyes and we see if there is any misalignment, you know, if the eyes are otherwise okay. But now we are saying that you should at least look at the red reflex. So while you do a torch examination, so you look for any gross abnormalities, you know, like something like if the baby doesn't have an eye, for example, that would be clearly an ophthalmos. That would be clearly apparent to anyone. But there's some problems that are not visible on the torchlight examination, for example, which are inside the eye. This could be congenital cataract, congenital retinoblastoma, things like that. So you will only come to know when you do a red reflex. A red reflex test is when you use a direct ophthalmoscope. Again, it's a very simple handheld instrument. It can come in your pocket, okay? So you just use that instrument, you look inside the eye of the newborn. It gives you a red reflection from the back, the retina of the eye, and you come to know that if you're looking at that red reflex, you know that, you know, the entire media is clear, and you can look right at the back of the newborn's eye, and usually it would tell you if there is a gross problem. So you're able to detect it timely and refer the newborn for subsequent assessment. So this is the second test, that you should do a red reflex to detect any eye abnormalities. And the third thing is the hearing impairment. And that is again another bedside test, which is called TEOE, or it could be an automated ABR. You'll find all the details in the recommendations document. So you do put a probe just like a earphone in the baby's ears, and it will give you an automated result in terms of whether the newborn is passing or failing the hearing test. So we say that you could use any of these technologies. Again, it takes bedside only maximum of 10 minutes to do this test, especially if the infant is sleeping and you have a quiet room, you can do it within 5 to 10 minutes, and it can be done even by a nurse or a midwife in a routine hospital. So these are the 3 new recommendations on universal screening of the newborn. Sorry for taking a little bit of a time here, but I really wanted to, help everybody understand that this is not some kind of a lab screening or, lab test or invasive procedure that we are talking about. It is all these 3 are simple bedside screening, which would help us detect any significant conditions in the newborn. Next slide, please, Shwe. Yeah, now coming to the nutritional interventions of the newborn. Neonatal vitamin A supplementation. I know that it's not a routine practice in many of the countries in the region, but just to mention that it is not recommended to reduce neonatal and infant mortality because it is being practiced in some settings. And it is only recommended where, we have a documented high infant mortality and a high prevalence of maternal vitamin A deficiency, both of which I don't think apply to the Myanmar context. Next, please, Shwe. The other recommendation is on vitamin D supplementation. And the recommendation is that for the breastfed term infants, it is not recommended. It is recommended only in the context of rigorous research. So I don't know about Myanmar, but in many of the countries in the region, it is very routine practice to, kind of give vitamin D oral supplements to all babies. But what was seen in the evidence is that while it improves the vitamin D levels, it does not have any effect on the clinical outcomes in terms of bone density or improved growth or any other clinically significant outcomes, and comes with a cost. So there was not sufficient evidence to suggest that it is effective, and therefore it is not currently recommended, and it is recommended only in the context of rigorous research. Next, please, Shwe. The other recommendations are on, and I think this is the last slide, these are on early childhood development. These are from a previous guidelines, but I'll just speak a little bit to it. So all the newborns, all the infants and children should receive responsive care. And by responsive care, we mean that the parents or caregivers, they should understand the baby's signals, that the baby is ready to feed or the baby is in pain or stress. And they're also able to respond to those signals promptly, consistently, and appropriately. So if they should be able to do that, and the health providers should provide them the education, counseling, and support to help them recognize these signs in the babies and how to support them. Then all the infants and children should have early learning activities. And for the newborns in the postnatal period, it means that the newborns should be engaged in activities that allow the baby to interact with a person, place, or object in the environment. Okay, so it could be like maintaining an eye contact with the baby, smiling, talking, singing to the baby, or even gentle massage like we are recommending now. That would be considered as an early learning activity for the newborns. Then psychosocial now this is the third recommendation, is that whenever you are doing any kind of postnatal contact, any interaction with the newborns, any newborn services, these responsive caregiving, early learning, these are such simple things that they can be integrated, during any contact with the mothers and the newborns. So whether you are helping the mother and baby breastfeed, then at that time you can tell the mother, okay, you look into the baby's eye, you sing to the baby, or you smile at the baby, so these could be integrated within the existing services without any extra effort, simply by counseling the parents and by making the healthcare providers aware of these. And last but not the least, psychosocial interventions to support maternal mental health. So maternal mental health is very important to focus on in the postnatal period. And at least the health providers should inquire the mothers about their mental health, their social well-being at every postnatal contact. And they should provide the psychosocial support as part of these contacts. So with that, I think I will hand over to Mercedes unless there are any questions. Thank you. Sorry for taking too long, Mercedes.
No. It was very nice to hear you explaining all this. I will go now through some of the recommendations we have in the section on health systems, and it's mainly about postnatal care contacts, when they should happen, and where they can happen, or where it's recommended for postnatal care contact to happen. So as you can see on the slide, there's recommendations that were updated from the previous guideline we had on postnatal care. This is around the minimum length of stay, so for how long as a minimum women and babies should stay in hospital if it's a facility-based birth, as well as when women and babies should be seen and receive postnatal care. This is basically recommendations that remain unchanged from what we have recommended since 2014, although we relook at the evidence for both of them. One of the issues is that, and as I showed at the beginning of the presentation, even if these are recommendations that have been around for some years now, we still see that coverage is very low. Women in general don't stay in hospital enough time to be prepared, to get all the information, the support they need to go back home, or they don't see health providers and they don't receive postnatal care at home or in the community after birth. And this really it's something that needs to be reinforced. But what are the recommendations we have? So in the first 24 hours, women and babies should receive care in health facilities when birth occurred in a facility. If birth is at home, then there should be a first postnatal contact as early as possible after the birth within those 24 hours. And these 24 hours are very important because it's when a lot of the complications may arise and when some of these risks can be identified and then complications prevented. And that's our first contact. After those 24 hours, there will be at least another 3 contacts as recommended, and as you can see here. It doesn't mean that if they have additional needs, they need additional support, let's say with breastfeeding, they won't need more contacts, but this is the minimum. So 1 contact during the first week, around 2nd, 3rd day after birth, another contact during the 2nd week after birth, between day 7, day 14 after birth, and then another contact that is towards the end of how we define postnatal period, so around week 6, 42 days, and this contact is the one that will allow referral or like that continuum of care to either woman care and child care for the baby. So this has to be seen as the visit that would allow them to continue to have the healthcare checks and support that they need. Based on what I said and the low coverage and low quality we we see from the evidence, we really think that rising awareness of how important postnatal care is for both the woman and the baby is really important, and it has to happen at all levels of care and across different stakeholders in the community, including women and families themselves. We need to strengthen health facility infrastructure, so when women come and have their babies in health facilities, they can also stay and receive the care they need during those first 24 hours that are so important for them and the families. And of course, ensuring that there's financing systems in place and universal health coverage is one of the instruments we have now, also to ensure that women and babies can receive care during the postnatal period without facing any financial difficulties. There's new recommendations around discharge preparedness. This is the time when women and babies will be discharged home from health facilities. The guideline has recommendations on what are the criteria that should be looked at to see if woman and baby are ready to go back home. This includes checking on the woman's well-being, both physical but also emotional, and we have mentioned several times mental health issues and the support she might need. Checking whether skills and confidence of the woman to take care of herself, but also of the parents or any other family member or caregivers to care for the newborn, whether they know, for example, all the different practices that are recommended, as Shuchita just mentioned it to you. It might be also an opportunity to check on the home environment and ask certain questions about how the home is prepared to receive them back, and also to look at their ability, for example, to provide care, or whether they know where to go if there's any complication, and that care-seeking aspect behavior that is very important, as well as, for example, whether they already know where to go, whether they will receive someone at home to do the subsequent postnatal care contexts that are recommended. All this is to ensure that that transition between the hospital and home goes well for women, babies, and families, and that there's those linkages already done with health services outside the hospital, in the community, or at home after discharge. What would be needed is for women and babies to stay in hospital for a sufficient time to be able to complete these assessments, to strengthen health workers' skills, to prepare women and parents for that transition to the home, and of course ensuring that those care pathways are in place and that health providers know how to guide women, and women know before being discharged where to go for subsequent routine care, or if they develop any complication. During the first week, we recommend that postnatal care contacts should be in the home. This will allow health workers to provide support in that home environment where women and babies are, support women self-care, provide family planning, care practices for the newborn as recommended in the guideline, child development, and support breastfeeding. And this is also an updated recommendation that continues to recommend that that first contact or the contacts that might be needed during the first week, better if they are at home rather than in the community or in a health facility. So to end this presentation, I wanted to mention that we are working on some tools to help countries implement these recommendations. And specifically wanted to mention a recommendation adaptation toolkit that we are currently finalizing and will be testing in some countries before we publish it. But it's basically a set of processes and tools that can help you to, in a more standard way, look at what is the situation in your country related to postnatal care, postnatal health, being able to adopt the postnatal care recommendations, looking at your current practices, looking at the current policies countries may have in place. It will help you to determine whether there's need to adapt some of these recommendations before they are integrated in your national guidelines, for example, and into routine practice, in training for health providers, and then move into implementation at a national and subnational or facility level. So stay tuned, and we anyway will be happy to share more about these tools during this presentation or later on. So in the presentation, you will have links to the guideline. We also have slide document, so it converts the guideline into a slide and some infographics that you can use or adapt for Myanmar. So in summary, WHO released in March 2022 updated comprehensive guidelines on postnatal care with a model of care that places women and newborn diets at the center, and paying attention on scaling up effective coverage of high quality postnatal care so that every woman and every baby receive the quality postnatal care that they need to survive and thrive. With this, I thank you very much for your attention, and I think that now we will have time to respond to questions, if any. Thanks very much.